Okay, so with all your permission, I'm starting the session. Good afternoon and welcome to one and all. Myself, Rupsha from Clarinet, the designated session assistant for a seamless experience of the session. Clarinet is very proud to be a digital partner of this event organized by National Neonatology Forum, Gujarat. And the topic of today's session is Lessons from Expert Neonatal Hyperbilirubinemia. Clarinet is India's most trusted and widely used digital platform with multiple enriching services exclusively for doctors. So let's begin today's session, for which I would like to invite Dr. Kunal sir. Over to you, sir. Kindly proceed with your talk.
Thank you, Rupsa. So this is our first session for the year, that is Neonatal Pathshala. We will be conducting this session every Wednesday. So first of all, I would like to invite Dr. Shwetal ma'am, who is our president for Gujarat State NNF. I will request her to speak few words.
Thank you so much, Dr. Kunal. One and all, very happy new year. We are once again back with our neonatal Pathshala. We will be having multiple important topics discussion for entire month. Every Wednesday, we will be having Pathshala. I request the audience, if you have some topic in your mind, please send us the request. We will definitely take that topic for the consideration. Today, we have Dr. Vaidyasaran with us. I would like to thank you so much, sir, for joining us as an expert. I have taken this neonatal hyperbilirubinemia because the recent updates from AAP 2022, we should be all must be knowing it has a medical legal implication, and the event is of connectors is declared as a never ever event. So what is that never ever event and how we can prevent that details Dr. Vaidyasaran will share with us. I would like to request Dr. Vishal Gohil to introduce our esteemed speaker, and we can go ahead with our session. Thank you so much, Dr. Koda. Thank you everyone for joining.
Yeah. Hello everyone. Yeah, so today's topic is regarding the neonatal hyperbilirubinemia. And as we know, this is the commonest thing we facing, not only in the NICU, but not in the OPD also. And I think last year, American Academy of Pediatrics launched the new guideline for jaundice. And I think there's a lots of, not controversy, I'd say, but there's a new update is launched last year. So I think Dr. Will be put some light on that part. So I welcome Dr. Vaidyasaran. He is a DM neonatologist. And hello. Hello. Yeah.
Good afternoon, sir. Good afternoon, sir.
So he is a DM neonatologist, and currently he is working as an assistant professor at Madras Medical College at Chennai. He has a 10 years experience of neonatology, and he is also senior consultant at Kamakshi Memorial Hospital, Chennai. He is a regional NRP as well as FDNC trainer, and he was treasurer in 2022-2023 Neonatology Association of Tamil Nadu, and he has a multiple national as well as international publication. He was awarded for V. Balgopalan Raju Award in year 2008. So I welcome you, sir, and over to you, sir.
Thank you very much, sir, for the nice introduction, and greetings from NNF Tamil Nadu on my behalf, on behalf of NNF Tamil Nadu, and I would like thank you. First of all, I would like to thank our NNF Gujarat chapter secretary, Madam Shwetal Bhatt, Madam, and Dr. Kunal sir and Dr. Vishal Gohil sir for having invited me to speak on this nice topic. This is today I'll be discussing the latest guidelines on management of neonatal hyperbilirubinemia. AAP. Shall I proceed, madam?
Yes, Dr. Vaidyasaran.
Yes, madam.
You may proceed.
Thank you. My screen is visible?
Yes, you need to share your slides. Can you do it full screen?
Yeah.
Vishal, can you help him to do the full screen?
Yeah.
Or-
I'm doing.
Yeah,
Okay, fine.
there is a slideshow. Yes. So at the above point, there
So
is
there's a
yeah.
Yeah.
there's a baseline, yeah, slideshow. There's a
It was below.
yeah, below there is a there's a marker over there.
That
Yeah,
one.
that one.
Yeah.
Yes, done. You can go ahead. Thank you.
Yes, sir. Thank you. Next slide. So this is the guideline from American Academy of Pediatrics, latest guideline 2022. So overview of my presentation will be prevention of. So I'll be dealing with how to prevent hyperbilirubinemia, assessment and monitoring for hyperbilirubinemia, treatment of hyperbilirubinemia. Next. So let's touch post-discharge follow-up and hospitalization policies. Right. So this article gives an update and replaces the 2004 American Academy of Pediatrics Clinical Practice Guideline. 2004 was the last, and it was amended in 2009 with a few modifications. After about 13 to 14 years, new recommendations has come. All the recommendations are based on the expert opinion and all after the recent studies, researchers published world over, and AAP has come out with the recommendations. These recommendations are formatted as key action statements that we'll be discussing. That is mentioned as KAS. This committee was worked from 2014 to 2022 to review the new evidence and has clarified and come out with the new guidelines. The first one is we are going to discuss about what is prevention of hyperbilirubinemia. So hyperbilirubinemia, as pediatricians and neonatologists, everyone would agree, more than 80% of the newborn infants have some degree of jaundice. So careful monitoring of these newborn infants and the application of appropriate treatments is utmost essential, because high bilirubin concentration, as we all know, will damage the brain and cause kernicterus and bilirubin-induced encephalopathy. And prevention of hyperbilirubinemia begins right before pregnancy, even in the antenatal period, and treating women who are at treating women who are at risk of developing developing antibodies for the red blood antigens, which can lead to hemolytic disease of the newborn, that is isoimmune hemolytic disease. If the mother was not screened for anti-RBC antibodies during pregnancy, evaluation and treatment should occur shortly after delivery. So prevention of hyperbilirubinemia is of utmost important if it is associated with isoimmune hemolytic disease. If there is a possibility of Rh negative or OAB incompatibility, and providing feeding support. These are the two key steps for prevention of hyperbilirubinemia. So as far as isoimmune hemolytic disease is concerned, so if the mother has not been already screened for ICT, indirect Coombs test, or if the mother is positive for antibody screen, that is ICT is positive, baby has to immediately undergo DCT test, direct antiglobulin test, immediately after delivery, and blood grouping typing as soon as possible. If the infant is found DAT positive, that is direct antiglobulin test, or DCT positive, the baby has to be assessed for the presence or absence of hyperbilirubinemia neurotoxicity risk factors, and the baby has to be under intense monitoring. If the baby is found to be DCT negative, and we can be little relaxed, this bilirubinemia is not of antibody induced, that is not of immune nature. So sometimes mother may be ICT positive because of receiving antiglobulin late in the pregnancy. So in that case, baby may be DCT positive, but will not show any signs of hemolysis. That is of reassuring type. If the mother is antibody ICT positive and baby is positive, there is high likelihood that these babies may land up in hemolytic jaundice and high risk of hyperbilirubinemia. So first statement comes that if the mother is positive or antibody status is unknown, babies should undergo DCT and immediate blood typing should be done immediately after delivery. This is the first recommendation for prevention of hyperbilirubinemia. The second recommendation to prevent hyperbilirubinemia by AAP would be the providing feeding support. We all know exclusive breastfeeding and hyperbilirubinemia are very much associated, strongly associated. Jaundice in breastfeeding infants may be of two types. One is breastfeeding failure jaundice, we simply call it as breastfeeding jaundice, or it may be breast milk jaundice, depending upon the time of onset. So breastfeeding jaundice occurs early in the first week of life, whereas the breast milk jaundice occurs in the later part of the life. And breastfeeding jaundice is due to lactation failure, some issues with the lactation due to decreased milk intake, suboptimal breastfeeding, and baby may show signs of dehydration, weight loss, and there may be high bilirubin levels in the first few days. Whereas breast milk jaundice, as we all know, it occurs in the later part of the first week with baby showing good weight gain, good urine output, and stool output. It is, we all know, it is due to high levels of some chemical substances, beta-glucuronidase in the breast milk that deconjugate the bilirubin and enhance the enterohepatic circulation. So these differentiation everyone should know, and implementation of lactation support policy is very important, and differentiation of these two jaundices treating pediatrician should know. And to prevent breastfeeding jaundice, one has to initiate breast milk feeding. Initiation should happen within first hour of birth with frequent feeding on demand. That is at least 8 feedings in a 24 hours, and baby should be monitored for urine output, stooling, weight loss, and everything should be monitored. Breast milk jaundice, we don't have to worry much because it usually settles, it peaks by 3rd to 4th week, and it may settle within a month. So the second statement should be oral supplementation. What we should not do, sir, my baby is, you are saying it is due to inadequate breast milk. Can we support with some other milk? So states the AAP statement states that oral supplementation with water or dextrose water should not be provided to prevent hyperbilirubinemia. And decision about temporary supplementation with either donor breast milk or infant formula may be considered after discussion with the parents. So after prevention, the important topic what we are going to discuss will be assessment and monitoring for hyperbilirubinemia. So what are we going to assess? First, we are going to identify the risk factors for hyperbilirubinemia and identify the need for treatment, visual estimation of total serum bilirubin, transcutaneous bilirubin, something we are going to discuss, and how to evaluate a direct reacting or conjugated bilirubin. Why to identify the risk factors? So risk factors for hyperbilirubinemia, if the baby is found to have risk factors for hyperbilirubinemia, they require closer monitoring than those babies without risk factors. So we have to determine the presence of these risk factors by examining the infant, head to foot examining the infant and assessing the lab data. So bilirubin, whether it is direct or indirect, and other any lab evidence of hemolysis, and obtaining a good thorough family history of jaundice in the siblings or previous babies with jaundice. So these are the 2009 AAP risk factors for severe hyperbilirubinemia: pre-discharge TSB or transcutaneous bilirubin in the high intermediate or high risk zone, lower gestational age, exclusive breastfeeding, jaundice observed in 24 hours, in the first 24 hours, G6PD deficiency, isoimmune or hemolytic disease, previous sibling with jaundice, cephalometoma, or significant bruising, East Asian race. But 2022 guidelines has somehow come out with the same, almost the same guidelines, except that it has specifically come out with some important risk factors like Down syndrome, macrosomic infant of diabetic mothers, and exclusive breastfeeding with suboptimal intake, and almost the same risk factors as 2004 or 2009 guidelines, and previously reported risk factors like polycythemia, small for gestation, male sex, and maternal age more than 25, and these risk factors were removed. So after having identified the risk factors for hyperbilirubinemia, we have to identify the need for treatment, whether these babies, which are the babies require treatment. Decision to initiate phototherapy or escalate care are guided by the gestational age, our specific total serum bilirubin, and the presence or absence of risk factors for bilirubin neurotoxicity. So, key action statement 3 states that total serum bilirubin as a definitive test to be done to guide phototherapy and escalation of care decisions, including exchange transfusion. So whatever it is, total serum bilirubin should be done, and any decision regarding phototherapy or escalation care should be based on total serum bilirubin, not by visual examination alone. So apart from this, they have identified some more risk factors. Just now we described some hyperbilirubinemia risk factors. The 2022 recent guidelines has come out with other additional risk factors as neurotoxicity risk factors. What are those neurotoxicity risk factors? Gestational age less than 38 weeks, albumin less than 3 grams, isoimmune hemolytic disease, G6PD deficiency, sepsis, any significant clinical instability in the previous 24 hours. These are said to be the neurotoxicity risk factors. So this is very important because the previous guidelines does not say these neurotoxicity risk factors, and we have to differentiate these neurotoxicity risk factors from whatever I said, the previous just simple hyperbilirubinemia risk factors. The baby has just hyperbilirubinemia risk factors, you are going to keep monitoring the baby with just do intense monitoring. Whereas with the hyperbilirubinemia neurotoxicity risk factors, you are going to take this as into account and plot in the specific chart. We have a separate chart, phototherapy chart with risk factors, and those babies with neurotoxicity risk factors, and those babies without neurotoxicity risk factors that we are going to see in the subsequent slides. So previously acidemia was considered as significant lethargy, acidemia were considered as risk factors. Now those are removed. Acidemia can come as a part of clinical instability. So acidemia and significant lethargy were removed, and they have just put it as any clinical instability in the past 24 hours. So what is the role of visual inspection of jaundice? Does it not suffice? Anyone would so we have been senior pediatricians may say we have been giving phototherapy based on only visual inspection. So what is the role of so visual inspection, Orbida? Is it not a right to any way decide about phototherapy based on just visual inspection? Yes, there has been a study. It is published in Israel. It was found that there was a significant difference between the bilirubin assessed by visual inspection versus bilirubin actually estimated by blood. So differences were as great as 13 to 15 milligrams per deciliter. And what was reassuring was if the clinician's visual bilirubin estimate is less than 4 milligram, total serum bilirubin more than 12 milligram per deciliter is highly unlikely. So you can be just reassured that if the baby doesn't look icteric, and as per Kramer's rule, if it is less than 4 milligrams, you can be reassured that bilirubin cannot be much higher. But at the same time, you cannot be reassured if it is if the clinical estimate is 14 or 15, you cannot be just reassured that it is 14 or 15. It may be 14 or 15, or it may be some as high as 25 to 30 also. So visual estimation of total serum bilirubin is not just sufficient anymore. So visual assessment does not replace the need to obtain at least one screening total serum bilirubin or transcutaneous bilirubin. And visual assessment is supplementary to measuring total serum bilirubin and transcutaneous bilirubin. So key action statement 4 states that all infants should be visually assessed for jaundice at least every 12 hours following delivery until discharge, and total serum bilirubin or transcutaneous bilirubin should be measured as soon as possible for infants noted to be jaundiced. As soon as possible, and it is a mandatory to have at least one TSB or TCB before discharge. So what is the role of transcutaneous bilirubin then? Transcutaneous bilirubin or TSB should be measured between 24 to 48 hours, 24 to 48 hours after birth or before discharge, whichever is earlier. And total serum bilirubin should be measured if the transcutaneous bilirubin exceeds or is within 3 milligram per deciliter of the phototherapy treatment range. So you cannot believe if the TCB is more than 15, so it may be higher also. So you should not believe TCB when it is showing any number more than 15, and at the same time, you have to definitely confirm with the TSB if it is just within 3 milligram per deciliter of the phototherapy treatment threshold. So these are some limitations of the TCB. And also TCB, so more than 15, you cannot believe. If it is around 3 milligrams per deciliter around the phototherapy threshold, you cannot believe, confirm again by TSB. And for a baby who is already on phototherapy, you cannot be, for 24 hours, you cannot be using again transcutaneous bilirubin. You have to do invasive transcutaneous bilirubin, invasive blood testing for serum bilirubin. So the statement, key action statement 7 states that if more than one TCB or TSB measure is available, so rate of increase may be used to identify infants at risk. A rapid rate of increase more than 0.3 milligram per deciliter per hour in the first 24 hours or 0.2 milligram per deciliter per hour thereafter suggests hemolysis. For example, if on day 2, if the bilirubin, you have a value at the end of 24 hours, if the value is around 10, at the end of 48 hours, if you find a value around, around 10 to 20 means 10 milligram per deciliter in 24 hours, it's definitely more than 0.5 milligram per deciliter per day. A 0.5 milligram per deciliter per hour, it suggests ongoing hemolysis. So rapid rate of rise more than 0.3 or 0.2 milligram, 0.3 in the first 24 hours and 0.2 milligram per deciliter thereafter indicate there is an ongoing hemolysis. You have to do, you have to definitely do invasive screening. The invasive confirmed by total serum bilirubin, and you have to escalate care. So you have to perform DCT to rule out hemolysis. So the key action statement 8 states that if appropriate follow-up cannot be arranged for an infant, discharge may be delayed. For example, if you cannot decide, the bilirubin is around 14. The phototherapy threshold is 15. You cannot just, if it is 1 milligram per deciliter is less, you cannot be just reassured and sending the baby home. You have to, particularly, you cannot be assured that the baby will not come for follow-up. You have to retain the baby for next 24 hours and recheck the bilirubin, and then only you can discharge the baby. Or else, if the clinician decisions, you can initiate. There is evidence for sub-threshold initiation of phototherapy is there. I will come to you in the subsequent slide. So the next important thing is evaluating direct reacting or conjugated bilirubin. Direct or conjugated bilirubin are different. We have to know any direct bilirubin fraction more than 1 milligram is considered abnormal, or 0.3 milligram per deciliter of conjugated bilirubin is abnormal. So direct and conjugated are not Same, they are different. So conjugated constitutes a small amount of unconjugated bilirubin plus small amount of unconjugated bilirubin also in addition to conjugated bilirubin, because they react directly in a Vandenberg's reaction. So that is the direct bilirubin. So any value more than 1 is abnormal. Direct is abnormal. More than 0.3 of conjugated bilirubin is abnormal. So no more than 20% of the total is no longer considered as a necessary for diagnosis of cholestasis. So action statement 9 states that breastfed infants at 3 to 4 weeks of age or formula fed infants at 2 weeks of age who are still jaundiced and total bilirubin, direct bilirubin concentration should be measured to identify the possible cholestasis. So coming to the important part of this lecture, that is treatment of hyperbilirubinemia. So treatment comprises not only providing phototherapy and also monitoring the infants who are receiving phototherapy, and when to stop phototherapy and when to do appropriate follow-up after phototherapy to just look for rebound bilirubin, and when to escalate care, when to do escalate care, when to start IV fluids, adequate hydration, and when should we prepare for exchange transfusion. All these we are going to cover in the next slides. So providing phototherapy, the primary goal of phototherapy is to decrease the likelihood for need for escalation of care. Escalation of care, if it crosses a particular value, we have to escalate the care and ship the baby, because anytime baby may need exchange transfusion. That is called escalation of care. I'll come the next slide. So phototherapy should be given with appropriate LED blue light with a radiation of 30 microwatt per centimeter square per nanometer at a wavelength of around 475 nanometer. So indications, we know indications. If the baby's bilirubin TSB value cutoff crosses the phototherapy thresholds based on the gestational age in hours or day of life, and hyperbilirubinemia neurotoxicity risk factors, baby, you have to initiate phototherapy. And AAP has come out with certain charts and supplementary tables also. And these are the two charts which have been given. These two charts you can follow. So these two charts taken into account based on first chart. First one you can see this one. This is the phototherapy thresholds with those babies who do not have any hyperbilirubinemia neurotoxicity risk factor, as I mentioned earlier. So these are the babies who are having any one or more of the hyperbilirubinemia risk factors. Hyperbilirubinemia risk factors, I told, lower gestational age, sepsis, isoimmune hemolytic disease, or direct womb stress positive, all those things. So these are the two charts. One is no hyperbilirubinemia neurotoxicity risk factors. Other one is the hyperbilirubinemia neurotoxicity risk factors. So phototherapy thresholds. These are the two charts. Phototherapy thresholds. One having one or more neurotoxicity risk factors. So this risk factors, you can see these are the parameters taken into account: gestational age. Other one is the serum bilirubin. You plot on the y-axis, and age in hours. This chart is divided into two components. One is the topmost one is showing the age in hours. The bottom one is the after 3 days. The first chart shows still 72 hours, and the lower bottom one shows after 72 hours, 4th, 5th, 6th, 7th, 8th, 9th day till 14 days. It's clear? So phototherapy thresholds. So these two charts can be just divided into 4 charts just for the basis of to understand. We have just broken into 4 charts. So I told basically we divide into whether the baby has neurotoxicity risk factors or baby does not have any neurotoxicity risk factors. So these two are having first left hand side is the one without neurotoxicity risk factors. Actually, the chart is divided into 2 components. First 72 hours in the topmost, and after 72 hours till 14 days in the bottom. So less than 3 days and more than 3 days. So accordingly, you have to choose the chart. Which chart to choose? Whether the baby has neurotoxicity risk factors, you have to choose the appropriate chart. And if it is baby having less than 3 days, you have to choose that chart. So If you are not comfortable choosing the appropriate chart, AAP has come out with a table. So in this table, you can see for each gestation and each day of life and each completed hours after the completed day, they have given the bilirubin. You need not go into plot the bilirubin value on the appropriate chart. You can just look into the table and decide whether the baby needs phototherapy or not. For example, you can see after 13, so the baby has, if you want to look at the phototherapy threshold for 13 hours and 13 days and 13 hours, you can see 13 days and 13 hours, you can mark and see that baby requires, the phototherapy threshold is 21.8. Right? Clear? So 21.8 for baby who has completed 13 hours, 13 days and 13 hours, the phototherapy cutoff will be 21.8. Like that, for each gestation, AAP has come out with the table. In that table, you can just plot and take a decision whether to initiate phototherapy or not. So key action statements 10 states that intensive phototherapy is recommended at the total serum bilirubin threshold on the basis of gestational age, hyperbilirubinemia, neurotoxicity risk factors, and age of the infant in hours. So just a few minutes back, I told what is sub-threshold phototherapy. So, for example, I told if suppose the phototherapy threshold for a baby is 15, baby's value total serum bilirubin is coming at around 14.9. There arises a question whether to initiate phototherapy or to discharge the baby. So for this, there is an evidence as published in JAMA. In this, you can see in this paper, they have studied and found that and initiated phototherapy, sub-threshold phototherapy for newborns, 0.1 to 3 milligrams per deciliter below the appropriate AAP phototherapy threshold has prevented readmissions for phototherapy. So because if the cutoff is 15, you are discharging at 14.1 or 14.5, the baby is definitely going to come the next day or the day after next day for readmission for phototherapy. It is it places a huge stress on the part of the parents, family, and health cost burden. To avoid that, there is a evidence that based on this paper, you can initiate phototherapy if it is 0.1 to 3 milligram per deciliter below the AAP phototherapy thresholds. To avoid, definitely it reduces the incidence of readmission for phototherapy. And home-based phototherapy. Home-based phototherapy, there is a key action statement which states that babies who have been already discharged and develop a TSB, total serum bilirubin, above the phototherapy threshold, treatment with home LED-based phototherapy is considered an option, but not to those babies who are at risk. For example, isoimmunohemolytic disease. It's a known case of isoimmunohemolytic disease, was given phototherapy and gone home. Those babies, we cannot take a chance. We have to advise only in hospital phototherapy only. For those babies who are risk-free, stated by these following criteria. For example, if the gestational age is more than 38 weeks, and if the baby is more than 48 hours old, and if the baby is clinically well with adequate feeding, and when there are no known hyperbilirubinemia neurotoxicity risk factors, whatever I have mentioned earlier. What are the hyperbilirubinemia risk factors? Gestational age, isoimmunohemolytic anemia, sepsis, significant clinical instability in the past 24 hours. All those things are the hyperbilirubinemia neurotoxicity risk factors. When there are no such hyperbilirubinemia neurotoxicity risk factors and there is no previous phototherapy and total serum bilirubin is not more than 1 milligram per deciliter above the phototherapy threshold. For example, if the phototherapy threshold is 15 and the baby's value is 15.5, you can give home phototherapy. You cannot give home phototherapy if the baby's value is 16.5 or 17. when the cutoff threshold is 15, baby is 1 milligram per deciliter above the cutoff. So you cannot give home phototherapy if it is 17 or 16.5. You can give home phototherapy if the threshold is 15 and baby's value is 15.5 or 15.6, right? Right. So monitoring infants. So after assessment, we have to monitor the infants on phototherapy. So how to monitor the dose, irradiance, and time exposed? Everything should be monitored, and newborn's vital signs, including temperature, should be monitored every 8 hours, and the baby's hydration status, time intake, output, and everything, weight. Everything should be monitored, and follow-up of total serum bilirubin. And this is very important. Follow-up of total serum bilirubin. When would you advise, when would you repeat a bilirubin who is a baby on phototherapy? The timing is 6 to 12 hours after starting treatment, and earlier follow-up. Within 2 hours, you have to check repeat serum bilirubin for babies requiring escalation of care. What is escalation of care? I will just come in the next few slides. So expected response is decline of total serum bilirubin of at least 2 to 3 milligram per deciliter within 4 to 6 hours. Within 4 to 6 hours, the bilirubin after initiating phototherapy should drop by at least 2 to 3 milligrams per percent. So expected response, normal expected response, this fall will be 2 to 3 milligrams in 8 to 12 hours. If it is the response is less than the expected, interruptions in phototherapy should be minimized, and the total serum bilirubin should be rechecked within 4 to 6 hours rather than 8 to 12 hours. And if the total serum bilirubin is close to the exchange transfusion care, escalation of care should be considered. See, if the exchange transfusion cutoff is 21, if the baby's bilirubin is 19, these babies we have to monitor and we have to consider escalation of care. So the key action statement is total serum bilirubin should be measured within 12 hours after starting phototherapy, and the initial timing of total serum bilirubin measurement after starting phototherapy and frequency of total serum bilirubin during phototherapy should be guided by the age of the child, presence of hyperbilirubinemia, neurotoxicity risk factors. And total serum bilirubin should be measured daily for those babies on home phototherapy instead of 8 to 12 hours. And 4. So what are the things to monitor? Measure hemoglobin, hematocrit, or complete blood count. And direct Coombs test, those infants whose mother is ICT positive or OR RH negative group. And G6PD, if the jaundice cause of the jaundice is unknown. And total serum bilirubin increases despite intensive phototherapy, or when there are unexplained reasons for phototherapy, you have to do G6PD deficiency. And when to stop phototherapy, this is a very important thing. So just like that, we cannot stop 6 hours phototherapy stop, 12 hours phototherapy stop, 24 hours phototherapy stop. There are clear guidelines given by AAP. You have to stop phototherapy when the bilirubin is 2 milligrams per deciliter below the our specific threshold at the initiation of phototherapy. For example, if you have started phototherapy for 15 milligrams per deciliter, you can stop only when the bilirubin has come down below 13. That is, so you started at 15, you can stop only if it has come down to 13. You cannot just stop, just it is below the threshold. It has 14, you cannot stop. You have to stop only when the bilirubin has come below 13, right? 2 milligrams per deciliter below the our specific threshold. So longer period of phototherapy is considered when there are risk factors for hyperbilirubinemia. So rebound hyperbilirubinemia should be checked, is considered when the total serum bilirubin reaches the phototherapy threshold within 72 to 96 hours. There are risk factors for rebound hyperbilirubinemia. If the postnatal age is less than 48 hours at the start of phototherapy, hemolytic disease, gestation age less than 38 weeks, or higher total serum bilirubin at the time of stopping are the risk factors for rebound hyperbilirubinemia. And repeat bilirubin after stopping phototherapy is based on the risk of rebound hyperbilirubinemia. If any risk for rebound hyperbilirubinemia is present, repeat bilirubin to be checked after 6 to 12 hours after stopping phototherapy. If there are no risk of rebound hyperbilirubinemia, you can do repeat total serum bilirubin after 1 day, after 24 hours. So what is escalation of care? This is a new concept given in the latest AAP guidelines. So everyone should know this was not in the previous 2004 or 2009 guidelines. Escalation of care is what is total serum bilirubin is 2 milligram per deciliter below the exchange range. If I already told you, if the exchange range is 19 and the total serum bilirubin is 21 and the baby's level is 19, that is when you need to escalate the care. You have to ship the baby to NICU, discuss with the neonatologist, take a blood sample for cross matching, make everything ready for exchange transfusion. So exchange transfusion, escalation of care, you have to initiate intensive phototherapy, you have to even start fluid therapy, and you have to get ready with the IVIG also, and you have to do intense monitoring. So intensive phototherapy such that optimize its delivery, maximize the skin exposure using the light sources from above, below, double surface, all those things. So IV hydration is a part of escalation of care. You have to give extra at a maintenance rate of 80 ml per kg per day for less than 48 hours old, and 80 to 100 ml per kg per day for those babies 48 hours old. So IV hydration should be considered when the babies are considered for escalation of care. Right? So IVIG, selective use of IVIG for those babies with RH negative situations or OAB incompatibility situation. Dose is 0.5 to 1 gram per kg. The dose everyone knows, and it can be repeated after 12 hours also. Monitoring. And so key action statement 20 states that escalation of care should be done when the bilirubin is 2 milligrams per deciliter below the exchange range, and IVIG should be considered in those positive for DCT, and the total serum bilirubin reaches or exceeds the escalation of care threshold. So whenever the total serum bilirubin exceeds the escalation of care, so ship the baby. So as I told, start adequate hydration, make IVIG appropriate, IVIG available, ship the baby to intensive care, level 3 care, and notify the blood bank, take blood samples for direct bilirubin, complete blood count, serum chemistries, type, and cross matching. So exchange transfusion. Criteria for exchange transfusion: signs of acute bilirubin encephalopathy, or the baby's bilirubin, irrespective of the total serum bilirubin value, the baby has bilirubin encephalopathy, you have to do exchange transfusion. Number 1. Number 2 criteria for exchange transfusions will be total serum bilirubin at or above the exchange transfusion threshold. So similarly for phototherapy charts, you have a exchange charts incorporating the gestational age factor, bilirubin in hours factor, and in hours or days age, postnatal age. You have to plot in the chart and decide whether the baby needs exchange transfusion or not. The third important criteria or indication for exchange transfusion would be bilirubin albumin ratio at or above the exchange transfusion threshold. So bilirubin albumin ratio should not be taken as a sole criteria, but it should be taken in conjunction with other indicators for exchange transfusion. So exchange transfusion also, I have broken the chart into less than 3 days and more than 3 days for better visibility. So here also, without hyperbilirubinemia risk factors, left-hand side charts, with one or more hyperbilirubinemia risk factors, right-hand side charts. So you have to choose the appropriate chart and decide and plot in the chart and decide whether the baby needs exchange transfusion or not, right? An exchange, so key action statement 22 states that urgent exchange transfusion should be performed for infants with signs of intermediate or advanced stages of acute bilirubin encephalopathy. And 23 key action statement, exchange transfusion should be performed if the total serum bilirubin at or above the exchange transfusion threshold, I told you. Right? So bilirubin albumin ratio, for want of time, I'm just rushing. So what is bilirubin albumin ratio? For example, if the bilirubin is 24 and the baby's albumin is 3, so bilirubin albumin ratio is 24 divided by 3 will be 8. For example, as the numerator increases, bilirubin albumin ratio will also increase. Not only the numerator, the denominator, the albumin. If the albumin level decreases, then also this ratio increases. So Again, so whenever there is hypoalbuminemia, the elevated bilirubin-albumin ratio leaves more binding sites, bilirubin binding sites, more free bilirubins is free to cause neurotoxicity. That is why bilirubin-albumin ratio is considered. Bilirubin-albumin ratio for more than 38 weeker, if there are no risk factors, 8 is a cutoff for exchange transfusion. If there are one or more neurotoxicity risk factors, 7.2. For lesser gestation age, 7.2, there are no neurotoxicity risk factors, and there are neurotoxicity risk factors. Even 6.8 is considered as a indications for exchange transfusion. So finally, we have seen charts for phototherapy, charts for exchange transfusion, and we have seen bilirubin-albumin ratio as an indicator for exchange transfusion. So how to do post-discharge follow-up? So 2004 guideline and subsequent 2009 guidelines recommended assessing the babies at risk for hyperbilirubinemia risk factors. So predicting the need for phototherapy after discharge. So they have used a tool. So total, the difference between the, so you can see the difference between the bilirubin concentration and the phototherapy threshold. For example, if the phototherapy threshold is 20 and the baby's bilirubin concentration is 80. So the difference between the bilirubin concentration and the phototherapy threshold is considered as, this is considered as a tool. Based on this, we can decide whether the baby needs discharge recommendation. So for example, previously discharge recommendations were based on the Bhutanese nomogram, no? So high risk, whether the baby falls into high risk zone, low risk zone, like that. But it does not take into account the gestational age or any other neurotoxicity risk factors. Whereas this difference, phototherapy threshold minus transcutaneous bilirubin or total serum bilirubin, if the levels, you can see based on this chart, you can plan and do appropriate discharge recommendation. For example, if it is the difference between the phototherapy threshold and the total serum bilirubin falls between 2 to 3.4, regardless of the age or discharge time, you have to do total serum bilirubin or transcutaneous bilirubin in 4 to 24 hours. So based on this chart, so it has the advantage that it has the advantage when to do follow up and when to come for review. So beginning at least 12 hours after birth, if discharge is being considered, the difference between the bilirubin concentration measured close to the discharge and the phototherapy threshold at the time of bilirubin measurement should be calculated and used to guide follow-up. So far we discussed, 2009 guidelines emphasizes more on hyperbilirubinemia neurotoxicity risk factors. As I mentioned, gestational age, significant clinical instability in the past 24 hours, sepsis, isoimmune hemolytic anemia, all these are considered as neurotoxicity risk factors. And those babies having neurotoxicity risk factors, we have to choose the appropriate chart for phototherapy or exchange. Phototherapy within 3 days or more than 3 days, exchange within 3 days or more than 3 days, and phototherapy with neurotoxicity risk factors or without neurotoxicity risk factors. Exchange chart with neurotoxicity risk factors or without neurotoxicity risk factors. So totally we'll be having around 4 charts. 2 charts for phototherapy with and without neurotoxicity risk factors. For exchange transfusion, we have 2 charts with and without neurotoxicity risk factors. So instead of 2 charts in the older guidelines, 2004 guidelines, we have 4 charts here. That is even split into 2 for our convenience. So 4 or 8 charts in the latest guidelines. And those who are finding difficult to view and plot in the chart, very well tables are available. AAP has given it the tables for each gestation, 38 weeks, 38, 39, 40, 37, 36, 35. For each gestation, they have given a table where you can mark the day of life and mark the bilirubin and see whether the baby, what is the cutoff for threshold and decide. So there is a chart, there is a table. After the chart and after the table, there is a simple tool called Billy tool. This is again, this Billy tool was recommended by American Academy of Pediatrics. At present, this is a software. It's an application. This is only a web application. This application anyone can use. With just a handy cell phone or in their laptop, they can open this and see whether the baby requires. There is a small video you can just go through. So suppose you have to just plot what is the birth date. So 31 May 2023, example, choose the birth timing and sampling date and sampling timing. If everything is marked and age in hours at the time of sampling, it automatically comes, and you can just see. You have to just mark what is the gestational age, and you have to choose the gestational age. Suppose 35 weeks is the gestational age, and you have to show whether any neurotoxicity risk factors present or not. Neurotoxicity risk factors present or not. If you plot the age in hours at the time of sampling and put the bilirubin value, presence or absence of neurotoxicity risk factors, automatically the tool gives you the recommendations. For example, in this case, the tool gives, see how the tool gives the recommendations. See, if using transcutaneous bilirubinometer, confirm with total serum bilirubin. The threshold is 11.3. If it is, and the baby qualifies for phototherapy. So see, you can see the baby qualifies for phototherapy, yes, and the escalation of care, no, and exchange transfusion, no. And this chart is automatically plotted by the software, and it is plotted. You can even print this chart and give it to your patient, or this chart can be printed and put it in the patient's file, or you can copy to the clipboard and take a printout and give it to the patient. See, so that is the advantage of this Billy tool. So 3 methods you can use. You can plot in the table by appropriate table with or without neurotoxicity risk factors in phototherapy chart and exchange chart. And if it is below 2, you have to, one thing you have to remember, not only the phototherapy chart, it qualifies for phototherapy. You have to plot in the exchange chart also. If it is within 2 milligrams per deciliter below the exchange threshold, that means you not only continue phototherapy, you have to escalate the level of care, escalation of care, and prepare everything for exchange transfusion also. Prepare everything and keep everything ready. So once this is done, so you can, this comes like this printout. So you can just print this as a paper and you can give to the patient. So to summarize, these are the recent changes. 2004-2009 guidelines they have just mentioned as a feeding support, and whereas 2022 guidelines again they have emphasized the importance of isoimmunization, anti-D immunoglobulin to the mother, and also if mother has not undergone screening test, baby has to undergo direct Coombs test immediately after birth and subsequent intense monitoring, and you can prevent bilirubin as in special situation, those cases. And breastfeeding jaundice or breast milk jaundice, appropriate feeding support, everything you have to give. Assessment and monitoring, you have to assess the risk factors. So they have classified and divided the risk factors as hyperbilirubinemia risk factors for intense monitoring and hyperbilirubinemia neurotoxicity risk factors. For based on that, you are going to plot in the appropriate chart and decide whether the baby crosses the phototherapy threshold or not. And risk assessment before discharge, you are doing with Bhutanese risk nomogram, whereas in the recent updated guidelines, you are doing phototherapy threshold minus TCB or TSB, and for each value, you have the appropriate recommendations. And you have only 2 charts, the phototherapy chart and exchange chart in the older guidelines. Now you have 4 charts, phototherapy and exchange, with and without neurotoxicity risk factor, that can be broken into 8 charts that has been given in the supplementary annex in the AAP also. Each chart broken into 2, less than 3 days and more than 3 days. And there are supplementary tables. Threshold for phototherapy increased by a narrow range that is considered safe based on the expert guidelines. So Thank you for patient listening. If there are any questions.
Yeah, thank you so much, sir. It's a really nice, crisp, and clear guideline, and you mentioned really nicely. And definitely, there's a few changes over there, and I think it is excellent talk from our side. So, can we take the question one by one? I think there's no any question in the chat. Anyone from the audience?
No, very good talk, Dr. Vaideshwaran. I actually joined late. I thought it was at 3:30, so I joined at 3:30. Then I found other it is already running for half an hour. So, but excellent.
No, excellent talk, Dr. Vaidyasaran,
Thank you,
especially
ma'am.
the practical implications. And Dr. Somshekhar sir is our advisor. We have also Uma ma'am with us. I'm really very thankful to our advisor.
Thank you, sir.
Thank you.
This was like you mentioned about all the practical implications. Still, the rollout of this guidelines is still, people need to know this and the practical implications. So this was really very good session, sir. Thank you so much for joining us. Thank you.
Thank you, madam. Thank you, madam.
So we
Thank you,
have
sir.
changed. We have changed. Somshika sir, we have changed time from 3 to 4 because of the resident. More resident can join. As 4 o'clock they have afternoon OPDs. So we thought that 3 to 4 will be benefit.
I remember, but जो habit था 3:30 बजे का वो 3:30
हाँ
बजे.
हाँ वो थोड़ा दिन लगेंगे sir. So by the time you will next you should like we will be gathering at 3 o'clock next Wednesday.
Yeah.
Now there is one question I think from Tashin Khan. Is can anyone
Is the
read?
TSPT prefer over DSPT? Is it triple surface phototherapy as compared to the double surface phototherapy? What do you prefer?
Dr. Vaideshwaran, can you stop sharing so we can see?
Yes, sir.
Stop.
Actually, nowadays the concept of I think triple surface phototherapy, double surface phototherapy have all gone after the advent of intensive phototherapy by LED lights. We don't talk about nowhere it's mentioned double surface, triple surface. It is only intensive phototherapy. You can increase the irradiance by reducing the distance between the baby and the light source, or nowadays a billy blanket or something, so that baby is exposed. The only thing you have to expose the baby to the light source. I mean, maximum surface should be exposed and the distance is minimized. That is intensive phototherapy. No more concept of double surface or triple surface holds good, I think.
There is a
So there's
question
another
from
question.
Kushang. Yes, Vishal, go ahead.
Yeah. So there's one question from Kushang. Is there any role or a recommendation of frequent changing the position of the baby under phototherapy?
Changing actually the baby's eyes and genitals are covered and the baby is naked. Baby himself will be rolling, turning. That itself will be sufficient, and there is no, I think, no strong guidelines or definitive evidence for frequent change of position. Previously, people used to do frequent changing of positions in phototherapy. Just we have to make sure that most of the maximal body surfaces are exposed. Probably not a frequent that calculated everything. And if for few hours, if the baby is this way and if the baby is turned this way, I don't think that's going to make a big difference. And particularly every 2 hours, we have to change the position like that. That nursing has to take care, and little bit of changing position definitely practically helps to expose the maximum body surface area under phototherapy.
There is another question. Is there any role of the heliotherapy?
So I'm not aware of heliotherapy.
Even I am not aware about the
Even I am
heliotherapy.
not aware.
I wanted to talk about the changing position. I think this is an old guideline. Before all this, we had double surface and all, when only single surface phototherapy was there. So they used to expose the front part, and after a few hours, turn it so the back gets exposed. So that was the rationale for the changing position, and like very old. But almost for like 20, 25, 30 years, we are having this both surfaces phototherapy. So that kind of does not work anymore as much. Okay.
Okay. We have
Is there
among us, there is Dr. Paresh Thakkar, sir. He is a professor in Department of Pediatrics, Baroda Medical College. Dr. Paresh, would you like to say something about heliotherapy or changing position?
heliotherapy is the sunlight actually. He
Acha.
mentioned that.
Okay, okay.
Okay.
Acha, sunlight. No, there is no
Okay.
role of sunlight. Yes.
Yeah.
Okay.
So
Unlike
Yes.
Dr. AAP has come out with the clear definition. Sunlight, of course, reduces the bilirubin level, but for it is for fear of sunburns and complication, dehydrations, exposing
and there's a
receipt.
frequency. I think there is a frequency is also like very 0.1% in the sunlight, which can reduce the bilirubin. So that's why it is not recommended. I think so. Is
Like
there
we
any
have
like a new guideline? We have a high threshold for the bilirubin. Do you think we can easily apply in the LMIC country like us, especially in the government setup or who is not affording bilirubin regularly? Because the AP guideline, you can see there is a lots of repetition of the bilirubin like 6 to 8 hourly or 12 hourly. And I think in our setup or in private, of course, we can do, but for the government or few setup, we can't do that much. So should we follow that new guideline or should we carry on with the old guideline?
new guideline says babies under phototherapy should be monitored 8 to 12 hours, 6 to 12 hours or 8 to 12 hours. Once it's enough, you take bilirubin. If suppose the baby's bilirubin is very high, close to the EOC range, escalation of care or exchange range, close to the range, you have to monitor very frequently, 4 to 6 hours once. 4 to 6 hours, whether bilirubin 4 to 6 hours or 8 to 12 hours. So if it is I think if the baby again doesn't have any neurotoxicity risk factors, not that, and the bilirubin is not very high and close to the exchange or escalation of care range, I don't think for practical purpose the treating physician can relax a little and take a little delayed samples also.
There is
And
also one
I could
practical
have one
question
evidence
from
that
my
subthreshold phototherapy and subthreshold phototherapy, even if the bilirubin value comes below the threshold range, also taking, continuing phototherapy, that is subthreshold phototherapy, avoids readmissions also.
Okay, there's one more practical question. Like if any baby who require the exchange transfusion, and suppose I think we know that the laboratory or blood bank will take at least 2-3 hours to make O negative blood. Should we give a repeat IVIG after the exchange because we already gave at a time of admission?
Actually, escalation of care, repeat IVIG should be considered. Repeat 12, every 12 hours you can consider, because the range is 0.5 to 1 grams per deciliter, 0.5 to 1 grams per kg. And the repeat dose can be considered after 12 hours. After 12 hours past means you can consider a repeat dose of IVIG. If it is 3 hours, I don't think within 3 hours we have to repeat.
Like practical purpose, so just we start the action before
No,
we
Vishal.
gave the IVIG.
No, Vishal. Dr. Bhutani also shared into Neocon 2022 that you should go with a crash cart approach. Now you should not. There has to be a timeline, and you cannot delay the exchange transfusion for more than 3 hours. So as soon as the baby is there, you go ahead with your double surface phototherapy. You start crash cart approach of managing the blood products
No, ma'am.
and
You are
start double
absolutely right.
surface phototherapy.
No. I am
But
not talking about the phototherapy. I just practical purpose.
no,
Like
I'm talking that you now NHS has declared the connectors as a never ever event, and so the excuse of we are not able to manage the blood is now they don't accept this thing, and so there is no role like keep on repeating the IVIG. You have to manage for the blood product and continue the exchange and continue the phototherapy.
Okay,
Frequent
because at least
IVIG
because at least 2-3 hours will take, to make a blood, because we need a mother sample and
So-
baby sample and everything.
But you have already
Actually-
given one IVIG.
Actually, escalation of care includes improving the hydration status, fluid therapy, considering IVIG while waiting for a exchange transfusion can avoid exchange transfusion, because if they suppose
Dr. Vaidyasaran, he is asking how many doses of IVIG you can repeat.
No, that is also not my question. My question would be, on addition, we give the IVIG, for example, and we did the exchange because we are waiting for the blood. So after doing an exchange, should we repeat with the irrespective of the result? Because in exchange, lots of blood IVIGs came out.
yes.
Yes, that's my question. It is not
Yes,
about
yes,
the
yes.
IVIG or yeah. So
You
that's
can
the thing.
definitely,
Okay.
you can consider,
Yeah.
because that will avoid second exchange transfusion. Second, if it's
Yeah,
definitely
so
hemolysis
should
is
we wait for a
proven,
12 hours? Or should we do like immediately after? Should we repeat the?
Yes,
That's
yes.
my question.
yes, hemolysis, if exchange is done, probably IVIG would have been washed out and
Yeah, so that's my question,
washed out, and we can consider IVIG at least to avoid subsequent second exchange transfusion.
So just a bit to talk about heliotherapy. I think it was discussed, but there's a systematic review published 2022, and it talks about that there is not enough evidence, because there were some studies published in 2016 and 2018 saying that it was of benefit. So, but I think as a guideline, as what you said, we should not be using it, especially in India, because many of them would get hypothermic, and most importantly, delay in getting the patients to for treatment of jaundice. So you might come out with higher values rather than lower values if you say you can use sunlight therapy.
Okay.
It's basically a
Dr. Paresh,
filtered
would you like
sunlight.
to share your experience? We have Dr. Paresh with us, and he has worked on hyperbilirubinemia. So, Paresh, would you like to share any experience on repeating IVIG or heliotherapy, anything else?
Good afternoon, everyone. It was really nice talk. And regarding that sunlight, there are articles related to filtered sunlight, and they do help to some extent in the low resource countries. There is a chance that this may be of help in future, but as Somsekhar sir told, the systematic reviews show that probably there is not enough evidence to go for the filtered sunlight. But there is, like, if it is used with some filters, then sunlight has a role in decreasing the bilirubin levels.
Yeah, I agree. So the point is, the Cochrane review was very careful. And this might have been good maybe 30 years back, at least in India, 35 years. Now there is enough phototherapy everywhere, even including in sub-centers, well, not sub-centers, but district health centers. Also, I don't think it's an issue per se.
Yes.
Okay. And anyone has come across this study that repeating the IVIG, what I have reviewed and read, that as soon as we give IVIG, it binds. So the washing out of IVIG during exchange transfusion, the percentage will be very less. So how frequently it has to be repeated? I think if someone has reviewed that, we can share. Anyone have an idea how frequently we can repeat the IVIG after exchange transfusion? What could be the duration? Any literature?
Second dose is recommended after 12 hours, madam. Second
Yeah,
dose is
that I know, after 12 hours.
So
Dr. Vishal was asking about immediate repetition.
yeah, so we reviewed
Yes,
this one like long ago, but for the practical purpose, what we are doing, once we know that most of in private setup, I'm talking about private setup, that we know that that baby has a ICD positive, so that might need exchange. So we pre-book the blood before baby deliver. So in that case, we are not waiting for the IVG. We just do the sometime exchange transfusion early before, because we know that baby has already high drops. In high drop setup, definitely the exchange is one of the indication. So in that case, we are just, or either if in Prathama, like I talking about in Ahmedabad, we have Prathama laboratory, they can release the O negative blood immediately, like within half an hour we can receive. So in that case, we wait for the IVIG.
Okay. Fine. So can we conclude, Dr. Vishal?
Yeah. So,
Vishal?
thank thank you so much, sir. And I think it is a crisp and clear guideline. The only thing is, like we mentioned that the AAP guideline raised the threshold level of the phototherapy, and the practical purpose should be apply. I think in private setup we are already applying. For government setup we haven't know that how much follow up. There's a lots of patient coming over there. So should we follow that one? But as per recommendation, I think we should follow the newer guideline, AAP 2022. We could not know from the NNF or either any IAP NeoChap regarding what we need to do for that one. For practical purpose, I think we should follow that one because it reduces the rate of the chronic tears and everything. They also enroll the new risk factor for neonatal hyperbilirubinemia, and we should follow that one. And the guideline regarding the phototherapy, we should follow the chart. We should break down in the two part, less than 3 days or more than 3 days, as sir mentioned, and same for the extend transfusion. And there is a crisp and clear guideline for the IVIG and albumin. So we should follow that one thoroughly. Anyone want to add anything else? Dr. Sir, Somsekar sir, Svetal madam? Because
I
it's
wanted
still,
to add
I
that
think,
AAP 2022 guidelines talk about home-based therapy, home-based phototherapy, which is still not feasible in our setup. And yes, we should come up with our own studies comparing the old and the new guidelines. And in near future, we'll definitely get some insight from the NNF as well as the IOP NeoChip. Till then, yes, connectors is a never-ever event, and the preventive strategies are easy to implement. Regarding government setup, Vishal, most of the government setup in Gujarat has a transcutaneous bilirubinometer. So I think we can definitely follow these guidelines. Yes, I am really worried about the private setup where the transcutaneous bilirubinometer is not there, and frequent sampling will be a difficult task. So as much as possible, we should definitely follow the guidelines, and we should create our own evidences for hyperbilirubinemia management. Thank you so much.
Yeah.
thank you so much, ma'am. Thank you.
Thank you so much, everyone, for extending us the opportunity to host the session. So with all your permission, I would like to sign off here and looking forward to host you again. Thank you so much.
Thank you so
Thank you.
much. Thank
Bye
you.
bye. Bye everyone. Bye.
Bye.
Thank you, sir.
Thank
Thank
you,
you, ma'am.
Vedasan.
Thank you.
Thank you.
Thank you, sir.